Okay. So, with everyone's permission, I'm starting with today's live now. Greetings and a warm welcome to all the dignitaries present here. I'm Shwastika from Team Clarnet, serving as the allocated session assistant to ensure a seamless experience. Clarnet is India's most trusted and widely used digital platform, offering a multitude of arranging services exclusively for doctors. Clarnet is slated to be chosen as a digital partner for this event organized by Indian College of Anesthesiologists. So today's focus would be recognition and rescue in anesthesia. Let's begin today's session, for which I would like to invite Dr. Jayashree Sood ma'am to take over. Over to you, ma'am.
Thank you, Swastika. It's a great pleasure that we are hosting the 267th webinar, which we have been conducting every Wednesday consecutively. And it's really a proud moment because today we have Dr. Pankaj Kundra with us, who is such an eminent faculty and eminent anesthesiologist of not only the country, but he's well known abroad as well. And it's a real proud moment for us, Dr. Pankaj. Thank you so much. Dr. Pankaj Kundra, known to everybody, but he needs a formal introduction. He's the professor of Department of Anesthesiology and Critical Care at JIPMER, Pondicherry. And he's also the honorary dean of the School of Medicine, Pondicherry University. With him, he has team members from Puducherry, JIPMER, and it's a real pleasure on the topic that especially that they've been talking about will be recognition and rescue in anesthesia, such an important topic where we all have to be alert and take swift action. So Pankaj, thank you so much, and you may please start the webinar. Thank you.
Thank you, Madam Sood. It's a pleasure to be here with you. And whenever you call up, it's very difficult to say no. So thanks a lot for giving us opportunity, especially all of us from JIPMER in Pondicherry. And we look forward for this academic event. So there are three speakers for today's session, which the session is entitled as Recognition and Rescue in Anesthetic Systemic Toxicity, Malignant Hyperthermia, and Anaphylaxis. So these are the three topics which will be dealt today. So with great pleasure, I would like to introduce the three speakers today. Dr. Stalin is Professor of Anesthesiology at JIPMER Pondicherry, and he will be talking about systemic toxicity. Following that, we have Dr. Banupriya. She is Assistant Professor of Anesthesia, alumni of AIIMS New Delhi, and she will be talking about malignant hyperthermia. And then we have Dr. Sireesha. She is also Assistant Professor of Anesthesiology. She has done an MD from JIPMER itself. And now she will be talking about anaphylaxis. So these are the three topics which we plan to discuss. Each of them would be taking a session for about 20 to 22 minutes. And at the end of all the three sessions, we can have the question and answers, which can be put up in the chat box. So those questions can be put forward to the speakers and they can respond to that. So I welcome Dr. Stalin to start the proceedings. Dr. Stalin, the stage is yours. Thank you.
Thank you, sir. Thanks for this kind words, sir. I hope my slide is visible.
Yeah, we can see the slides. You can start, please.
Yeah. A very good evening to one and all. At this outset, I would like to thank Indian College of Anesthesiologists for giving me this opportunity. I also thank all the participants who have joined on a festival day. Thank you so much. Happy Ganesh Chaturthi to all of you. So, the topic on which I'm going to talk today is local anesthetic systemic toxicity. As anesthesiologists, we use local anesthetics in our daily practice, and we should be prepared to face this particular complication. And let's go into the topic. I would like to disclose that I don't have any conflicts of interest to declare. Now, local anesthetic systemic toxicity is a rare but serious complication. So it can happen any day during your practice. It can happen in your operating room or in the outside the operating room, and you are expected to manage these patients in a swift way. When it comes to incidents, Currently, though we don't have any recent data, a 2013 article shows that 1 in every 1,000 peripheral nerve blocks and 0.1 in every 1,000 epidural blocks, there is incidence of local anesthetic toxicity. This is because this is where we use large volume of local anesthetics, and so we can expect this toxicity in this set of patients. What is more interesting is 50% of loss happens in the hands of non-anesthesiology specialists like ophthalmologists, surgeons, dental surgeons, and nowadays even emergency physicians are using more and more local anesthetics. So the incidences keep on increasing. And to manage this, early recognition and intervention is very critical to prevent any morbidity and mortality. So with this, to highlight the importance of this topic, I'd like to share one of a personal experience which happened just recently, exactly a week before last Wednesday, where you can see the ENT surgeons were operating on a patient. When you have close look, they're operating on the undersurface of the tongue. You can see that the patient is intubated. So what is so special? ENT surgeon operating on an undersurface of the tongue? You all must be thinking, what is so different in this case? What if we say this is happening in a local OT where there is no anesthesia machine, there are no multipara monitors, and what if I say this patient has actually come for a deviated nest septum with a deviated nest septum for septoplasty, which was planned under local anesthesia by the residents? What exactly happened? The patient developed convulsion just before start of the surgery, and he had a very bad tongue bite injury. We were called for help. When we reached, the patient was in a post-ictal state, completely agitated. 5-6 people are holding the patient. He is trying to jump out of the OT table, and he was profusely bleeding from the oral cavity. After making sure his hemodynamics was stable and thorough sectioning of the oral cavity, we immediately intubated the patient, and they went on to do trunk repair in the local table itself. You can see we are using even the basic monitors, don't have multipara monitors. We are using the basic NIBP machines during the course of the repair. When we inquired what exactly happened with the resident, they said 30 minutes before the surgery, they did a nasal packing with 4% lignocaine plus adrenaline, around 20 ml. They packed using 6 packs of cotton packs. And on top of it, when the patient was shifted to the OT table, they tried to infiltrate both the sides of the nasal septum with the 20 ml of 2% lignocaine with adrenaline. When they're about to inject the last few ml of lignocaine, the patient started becoming agitated and throat convulsions. So these sort of events can happen on any given day, and we should be prepared to manage, or we'll be called as experts to manage these cases. So it's very important we are thorough about managing these particular complications. So this is a post-op photograph of the patient, where you can see he also had a sharp denture, which has led to multiple lacerations in the undersurface of the tongue. Now, with this, for the next 15 minutes, I'm going to cover this topic under these following headings. First, I'll be talking about the mechanism of toxicity, how actually the toxicity happens, and what are the risk factors. Is the risk factors a patient or the drug or the technique? That we'll discuss in detail. Followed by that, I'll be talking about the clinical features, how usually they present, and what are the treatment options which are available. And finally, the most important thing, how we can prevent this from happening in our daily practice. To start with mechanism of toxicity, the most important prerequisite for the toxicity to happen is there should be excessive plasma concentration of local anesthetic. How it can happen? It can happen because of 2 reasons. One, there is an inadvertent intravascular injection. You are intended to infiltrate your facial planes or perineural region, but you unintentionally injected into the intravascular space. The other reason why it can happen is, though you infiltrated in the facial plane, that area is very highly vascular and fast absorption happens from the local side, which leads to increased concentration in the plasma. These are the 2 contributing factors which needs to happen for the toxicity to occur. Now, looking at the cellular level, we all know that when local anesthetic is given, it usually acts at the voltage-gated sodium channels. For that, it has to cross the plasma membrane. In the normal concentration, it also acts at the calcium as well as potassium channels. But what happens if a huge volume of local anesthetic enters the blood? It acts on various other receptors like ryanodine receptors, PKA receptors, or even receptors within the mitochondria, which leads to this toxicity. Now, how this toxicity affects? It usually manifests as either CNS effects or cardiac. In CNS, usually it will be biphasic. Biphasic, what I mean is, you start with excitation followed by inhibition. Excitation, the patient will be agitated through convulsion, followed by that, you will develop respiratory depression and coma. When it comes to cardiac, it causes both electrophysiological changes as well as contractile dysfunction. So we should be prepared to manage these cases. Now, next I move on to the next part, that is the risk factors. The risk factors can be either the drug that you are going to use, or the patient, or the technique that you are going to employ for a particular patient. When it comes to drug, whether you are using ester or amide, that's going to make a difference. And what dose you are going to use, that is going to majorly influence the incidence of toxicity. When it comes to patient, what is the age of the patient and whether the patient is having any comorbidities, that's going to have an effect. Similarly, the technique is what site you are planning to block, whether that site has increased risk of toxicity, and what type of infusion. Are you going to give a single shot? Are you going to give repeated boluses or continuous infusion? All those going to matter whether a particular patient is going to develop toxicity or not. Let's start with the drug. When it comes to drug, we should understand a particular terminology, that is cardiovascular collapse versus CNS ratio. That is the ratio of the dose required to cause cardiovascular collapse to the dose that is required to cause seizures. So the most commonly used local anesthetics are lignocaine, bupivacaine, and the recent ones ropivacaine and levobupivacaine. Where do they stand as far as this CC-CNS ratio is concerned? Lignocaine is got high CC-CNS ratio. What I mean by that, with a high dose only, the cardiac complications will develop. Whereas with the initial doses, there will be CNS complications. So usually at the range of around 6 mics per ml, the neurological symptoms will appear. Whenever the concentration goes beyond 10 mics per ml, the cardiovascular compromise happens. Whereas bupivacaine is opposite to lignocaine. It has got low CC-CNS ratio because of its more lipophilic and greater affinity for voltage-gated sodium channels. Along with this, it has also got a vasodilatory property, which makes it get absorbed very rapidly from the area of injection to the vascular system. What about the recent drugs, the ropivacaine and levobupivacaine, which are the S enantiomers of bupivacaine? We know that they are more cardiac safe drugs. Why so? Because they have a higher CC-CNS ratio compared to bupivacaine. They also have a dose-dependent vasoactive properties, which makes them duration prolonged and decreases the systemic absorption also. Now, moving on to the most important aspect, dose. We all know, we teach our residents that this, for every local anesthetic, there is a maximum dose that can be used for a plain molecule as well as with adrenaline. But where exactly the mistake happens is, let's say, for a lidocaine, the maximum dose that allowed is 5 milligram per kg. But what we should understand is the maximum dose that is allowed is only 350 milligram. If a patient of 100 kg comes, the majority of us, what we do mistake is we multiply by 5 mg per kg and we think that 500 milligram is allowed. Similarly, with adrenaline, we think 700 milligram is allowed, but that's not the case. You should know the maximum dose irrespective of whatever the weight of the patient. We should not go beyond certain dose. So what I do is whenever a patient's weight is above 70 or 80, I stick to 350 or 500. When it is below 70 or 80, I calculate based on the per kg calculation. And whatever your calculation is, don't try to achieve this maximum dose. Try to use the lowest possible for a particular block. At the same time, calculate the dose not for the actual weight of the patient, calculate for the lean body weight of the patient. If you do this, we can avoid majority of the toxic symptoms. Now, coming to patient factors, extremes of age are at high risk. Let's say neonates and infants are at high risk because of there is a decreased alpha-1 acid glycoprotein, and they also have immature hepatic function to metabolize your local anesthetics. Similarly, old age is also of higher risk because of the decreased skeletal mass and decreased clearance of local anesthetics. So we need to be careful whenever extremes of age are coming and we are trying to perform a block. Similarly, patients with comorbidities like hepatic dysfunction, cardiac dysfunction, and conductive disorders, we need to be careful. And the most important is pregnant patient, where there is chances of rapid local anesthetic absorption and high peak free plasma concentration can be achieved very easily. So we need to be careful. When you are performing epidural in this patient, because of the venous engorgement, the absorption from the epidural site is also quite fast and they are likely to develop toxicity. So it is always recommended when you come across any of these patients, you try to reduce your actual dose to 15 to 20% to the actual dose that you are planning to give to the patient. Now, coming to the site and technique, we were always taught that the most vascular areas, if you are trying to perform block, there's likely chance of toxicity. So the intercostal nerve blocks is at high risk, followed by epidural, followed by brachial plexus block. But the clinical data shows little different. it shows that paravertebral is the high risk area for toxicity to happen, followed by any upper limb and then any lower limb. But it doesn't end here. There are reports of toxicity with various other blocks, like facial plane blocks. Recently, there are lots of reports after tab block, lignocaine toxicity happening after tab block. And one area where it is usually overlooked is the topical anesthesia of oropharynx and airway, which we do for our awake fiber optic. There are also reports of toxicity after this topical anesthesia also. And areas like intravenous regional anesthesia and tumescent anesthesia also, you can expect toxicity to happen and you should be prepared for that. Wherever is the site, whenever you perform continuous or repeated bolus, there is high risk of toxicity compared to single shot. So try to use single shot compared to repeated boluses or continuous infusion, if it permits. Now, moving on to clinical features, we all know the CNS symptoms usually starts with prodromal symptoms like perioral paresthesia, metallic taste, and tinnitus, whereas later part they develop seizures, agitation, respiratory depression, and loss of consciousness. As I said in the early, initially there will be excitation followed by depression features like respiratory depression and coma. When it comes to cardiovascular system, they usually present as hypotension, bradycardia, various types of conduction blocks, and eventually they develop ventricular arrhythmias and cardiac arrest. Now, how will you diagnose? Is there a way to diagnose? The diagnosis is purely clinical. You should have a suspicion whenever you are performing block. If patient develops any of the symptoms, you should definitely suspect toxicity. There is no specific lab test to immediately diagnose the toxicity of local anesthetics, and you should rule out other causes of seizures and stroke. It can happen immediately while you are performing the block, or it can happen later also, after an hour or so also. If you have accidentally injected intravenous, it will happen immediately. If it's because of rapid absorption from the surrounding tissue, it can happen even after 1 hour also. What we should understand is atypical presentation is the most common way of presentation. Every patient need not present like typically the prodromal symptom followed by CNS and then the CVS. Some patient may directly present with CVS symptoms. Some patients may not have any prodromal symptom. They directly throw convulsion like the way it happened in our case. So we should be prepared to understand that the atypical presentation is more common and expect such presentations. Now moving on to treatment, the immediate treatment is stop injection. Whenever you suspect, if it's in the intravascular and the patient is showing some symptoms, immediately stop, don't take chance. Call for help or your resuscitation team if it's in the non-operating room areas. Try to maintain airway and oxygenation. These are basic things you should do, irrespective of whether you use lignocaine or bupivacaine. Now, the ultimate treatment is 3 pillars. 1, seizure management. 2, intralipids. And 3rd is the advanced cardiac life support. When it comes to seizure management, like any other seizures, you should try to manage it with intravenous benzodiazepines or small doses of propofol, and make sure that you supplement them with oxygen during managing seizures. Now, the second pillar is intralipids, which is the definitive treatment for local anesthetic toxicity. We call it as lipid resuscitation therapy or LRT. How does this intralipid act? It acts in a multimodal way. The first most common way it acts is scavenging effect or lipid sink, where it has the capacity to take up all the lipophilic molecules and transfer them to various sites of storage and excretion in the blood. Now, the other effect is direct cardiodynamic effect. Because of its volume and its direct effect, it can even improve the cardiac output. But for this to happen, the local anesthetic concentration in the cardiac muscle should be below certain threshold level. Otherwise, this effect will not come into play when you are resuscitating the patient. Some people think that propofol, being in the same look-alike structures, it's an alternative to lipid emulsion. It's definitely not a substitute for lipid emulsion, and you should not try it. It may lead to further hemodynamic compromise, and you may lose the patient also. Now, little about intralipid dose. Usually, you give a dose of start with the dose of 1.5 ml per kg if the weight is less than 70. And if it is anything above 70, don't calculate again for 1.5 ml. You restrict yourself to only 100 ml, and this should be given over 2 to 3 minutes. These are recommendations given by ASRA. And this should be followed by infusion of 0.25 ml per kg per minute. Again, if the weight is less than 70 kg, if it is above, restrict yourself to 200 to 250 ml over 15 to 20 minutes. If with this, the patient is not improving, is still deteriorating, you can repeat bolus or consider increasing the infusions to 0.5 ml per kg per minute. But whatever happens, the maximum recommended dose should not cross beyond 12 ml per kg. Throughout the course of resuscitation in a particular patient, you should make sure that you don't use more than 12 ml per kg of lipid emulsions. Now, this should be stored at 25 degrees centigrade, but at the same time, you should not freeze. So the area should be equipped with a refrigerator. It has got a shelf life of 24 months. So even though it is rare, once you procure, you can keep it in your fridge for 24 hours for any emergencies. But once opened, it should be discarded. It should not be reused again. It's available in various packs like 100, 250, and 500 ml to make it convenient for our use. And the price ranges from between 500 to 2000 rupees based upon the volume. And whenever you use, you make sure that you report it in the registry, that is www.lipidrescue.org, for further research and data. Now, once you are resuscitated patient, can we shift the patient to the ward? No. They should be monitored at least for a certain period of time based upon whether a patient has developed CNS symptoms or CVS features. If it is CVS, you should monitor at least for 6 hours. And if it is CNS, you should monitor at least for 2 hours. While doing so, if you have used intralipids, you should also look for side effects of intralipids. Usually, some patients develop bronchospasm, hyperamylasemia, acute kidney injury, or fat embolism. You should be anticipate if you have used the full dose of intralipids in a particular patient. Now, when it comes to advanced cardiac life support, most of the steps remains the same, like the chest compression, activating emergency, ventilation, those remain same. The major difference is with epinephrine. You should not use the standard dose of epinephrine because it can worsen the acidosis and can precipitate arrhythmias also because of sudden increase in afterload. So when it comes to cardiac arrest, because of local anesthetic systemic toxicity, a smaller dose of less than 1 mics per kg is recommended. You should avoid vasopressins, calcium channel blockers, beta blockers, or any other local anesthetics. The only antiarrhythmic that is recommended for this management is amiodarone. Now, if none of these are beneficial, the patient is still in arrest, you should think of cardiopulmonary bypass, preferably a VA ECMO, veno-arterial extracorporeal membrane oxygenation. Now, moving on to the last aspect of my presentation, that is prevention. Prevention is very important. Prevention is always better rather than letting the complication to happen and then manage it. How we can prevent? Before starting the procedure itself, you can do certain steps which will prevent your complications. During the procedure, you have to take certain measures which will make it a more safer procedure. At the same time, we should think of training our residents how to handle such situations. Now, when it comes to preparation, wherever you are performing block, make sure that there is a source of oxygen, the patient has been connected to standard monitoring, and there is an IVSS to handle any emergency situation. Yes, we always keep resuscitation equipment when we are performing the blocks. Along with it, now it is recommended that you also keep something called last rescue kit. What is this kit? It's nothing but what we said in the previous slides, that you should have an airway equipment in this kit. You should have benzodiazepines in case if the patient develops seizures. You should have lipid emulsions and also the ASRA checklist to emergency. If you want to refer what is the dose, how to go about managing this patient, that checklist should be available. This is an example. Everybody can have their own kit prepared and kept ready in the area of blocks where they are performing. This is the ASRA checklist for your reference, where they mention about how to go about step-by-step manner whenever you come across a patient with local anesthetic systemic toxicity. Now, I said certain things you can do during the procedure which will prevent the patient from developing toxicity. The first thing is follow a proper injection technique. What I mean by that is whenever you inject in small boluses of 3 to 5 ml and always make sure you aspirate before each injection. At the same time, you can consider using, like if we epidural, we use test dose. No, let's similar way we can consider using 10 to 15 mics of epinephrine as an intravascular marker if possible. That will help us to identify any intravascular injection immediately. And the most important thing is use of ultrasound. Whenever possible, use ultrasound. Studies have shown that use of ultrasound has brought down the incidence of loss to 60 to 65% because of its advantages like direct visualization of the spread of the drug. You can see that it is getting spread around the neuron and nerve tissue and not injected into the vascular system. At the same time, whenever we use ultrasound, as you know, it's going to be very specific around the nerve tissue. So we always use lesser dose compared to blind techniques. So in that way, even if it goes into the intravascular space, they don't reach to the highest concentration to cause toxicity. Now, I would like to spend some time on dose calculation during topicalization of airway. This is mostly overlooked. So we should address this area very specifically as we are preparing for our awake fiber optic intubation. We all know lignocaine is the most commonly used drug for this purpose, and it gets rapidly absorbed from upper and lower airway. Within 20 to 40 minutes, the peak blood concentration is reached. When it comes to topicalization, we have some leverage. Instead of regular 5 mg per kg, we can very well go to a dose of 9 mg per kg because we expect that some of the drugs gets lost during the secretion or the patient swallows and they don't get absorbed. For these reasons, you have an extra leverage. You can go up to 9 mg per kg. Even though you are using 9 mg per kg, you should be very careful about the total amount of volume that's getting into the particular patient. For that, the ASRA has released one checklist for how to go about managing difficult airway patients when you are planning an awake fiber optic. In that point number 7, they specifically want us to write down before doing the procedure how much volume you are going to use for nose, oropharynx, larynx, and trachea. Are you going to use any vasoconstrictor? At the same time, calculate your maximum dose, specifically mentioning how many sprays of 10%, how many ml of 2%, and how many ml of 4%. If we do this way, we will not overshoot and we will restrict ourselves within the toxic dose even when preparing for awake fiber optic intubation. Now, coming to training, this being a very rare event, many of the residents may not come across the event during their residency. So the best way to teach them is use simulation. Simulation can be of great help. This is what we do in our institute also. Whenever they enter the second year, we bring them to the simulation lab. We have a scenario on local anesthetic systemic toxicity, which we ask them to perform. These structured simulation scenarios help them to provide a safe environment to rehearse the protocols. At the same time, they also allow residents to practice identifying the symptoms and signs very early and try to intervene as per the protocol. And they also do better teamwork and communication. So whenever possible, whichever institute has simulation capacity, they should try to use it specifically to teach how to manage local anesthetic systemic toxicity. With this, the take-home message is last is rare, but potentially fatal. So we should be prepared to manage this. And with our intervention, we can save the patient. Early diagnosis and immediate intervention is critical. So we should train our residents how to identify early and intervene as quick as possible. But what I would say, prevention is the key. If possible, prevent. Don't allow it to happen. Finally, we should also raise awareness and educate our non-anesthesiologist colleagues because they have started using more and more local anesthetic nowadays, and we should anticipate toxicity happening there. And educating them will bring the incidence of toxicity even in non-OT room areas. Thank you so much for your patience.
Thank you very much, Dr. Stalin. Very lucid presentation and the points are well taken. Let's move on to the next speaker and the next topic. I invite now Dr. Banupriya. She'll be talking on malignant hyperthermia. So, Dr. Banupriya, please, let's move on. You are muted, Dr. Bhanu.
Yes, sir. Am I audible now, sir?
Yeah.
Yes. You're able to see my screen, sir?
Yeah, the slides are visible. You can go to the slideshow.
Okay. Now, sir?
The slideshow is, it's visible. Perfect.
Yes, sir. Okay.
Thank you.
Thank you so much, sir. I thank the Indian College of Anesthesiologists for giving me this opportunity to present in this forum. And today my topic is about malignant hyperthermia. Myself, Dr. Banupriya, I'm from assistant professor from JIPMER. And we'll start with a simple case scenario. We have an ASA1 patient who had an who was posted for laparoscopic appendicectomy. He had a very uneven food induction and intubation. After 30 minutes after starting of the surgery, the patient started developing rise in the EtCO2 levels, but there is no change in the peak pressure. We tried to increase the minute ventilation of the patient, but still there was no improvement in the EtCO2 levels, and it was keeping on increasing. Subsequently, the patient also developed some rise in the temperature, which also associated with tachycardia, and the patient also developed some amount of ventricular fibrillations. So this is the simple case scenario which we all can have at any point of time. So how we will go about this? What all differential diagnosis we'll be getting when we see such patients? So there are n number of differential diagnoses when we encounter such scenario. It starts from inadequate depth of anesthesia. It can be CO2 pneumoperitoneum when, especially in laparoscopic scenarios. It can be any amount of endocrine abnormalities like hyperthyroidism, thyroid crisis, and pheochromocytoma, which is undetected. And it also includes malignant hyperthermia, which is a concern for us. And that's what we'll be discussing today about. So in this session, we'll be discussing what is malignant hyperthermia and what is the occurrence of malignant hyperthermia in Western population and in our population, and what is the pathophysiology behind the occurrence of such disease, and how it manifests in the OR, and how we can go about, how we can manage such patients, and when we have a high-risk patient, how to manage a high-risk patient, and what we will do after an episode of malignant hyperthermia. So to start with, first we'll see what is malignant hyperthermia. Malignant hyperthermia, it is a pharmacogenetic disorder of skeletal muscle. It is mainly characterized by a hypermetabolic crisis, which is triggered by any anesthetic agents, like especially the volatile and inhalational anesthetic agents, and also the succinylcholine. This is mainly seen in genetically susceptible individuals. So we'll see what is the occurrence of malignant hyperthermia of PC. In the anesthetics administered all over the world, it happens in a wide range. It can be from 1 in 10,000 to 1 in 250,000. And if we see about the mortality, what is the chance of mortality? The mortality is also very high. And if we try to use dantrolene, the mortality can come down to less than 1.4 percentage. And if we see what is the proportion in pediatric and adult population, in 50% of all the malignant hyperthermia cases which has been reported, it is seen in the pediatric population. So if we see about what is the genetics role in this, there is mainly mutations in two receptors. The first one is the ryanodine receptors, and the second one is the calcium receptors that are dihydropyridine receptors. And the penetration can be variable. It can be both autosomal dominant as well as autosomal recessive. So first we'll see what is the neuromuscular transmission and how a neuromuscular transmission happens and how it affects and it causes malignant hyperthermia. So as we all can see in the neuromuscular transmission, in the NMJ junction, this is the neuromuscular junction, whenever there is an action potential traversing through the axon to the synaptic knob, there is activation of the voltage-gated calcium channels. And this causes the calcium to enter inside the synaptic knob and activation of the ACH vesicles. Once the acetylcholine-loaded vesicles get activated, they'll, by the process of exocytosis, they are released in the neuromuscular junction and the acetylcholine molecule will go and bind to the acetylcholine receptors, which are situated in the motor end plate. Once the acetylcholine receptor is activated, there will be sodium and potassium conductance, which causes action potential formation and depolarization of the perijunctional areas and the subsequent muscle fibers. Once the depolarization goes to the T tubules, there is also activation of the sarcoplasmic reticulum, and there will be release of calcium from the sarcoplasmic reticulum, which causes the further excitation contraction coupling. So why we are seeing all this physiology is we have to know about certain receptors called as, especially the ryanodine receptors. These ryanodine receptors are nothing but these are calcium channel receptors, and they are actually situated in the membranes of the sarcoplasmic reticulum of the skeletal muscles, and they also play a role in release of stored calcium from the sarcoplasmic reticulum into the cytoplasm, so that this calcium can go and activate the excitation contraction coupling. So how it does this? This is the T tubule, and this is a close-up of the neuromuscular, close-up of the muscle layer. In the T tubule, when an action potential traverses to the T tubule, there is an activation of the DHPR receptors, that is the dihydropyridine receptor, which in turn activates the ryanodine receptors. Upon activation of the ryanodine receptor, there will be release of calcium from the sarcoplasmic reticulum towards the cytoplasm. This increase in the calcium concentration in the cytoplasm will activate the actin-myosin molecules and can cause contraction. So what happens in the disease process is there is a mutation in the ryanodine receptor. So because of that, what happens? There will be constant increase in the calcium in the cytoplasm. Once there is a calcium accumulation in the cytoplasm or in the muscle, what happens? There is a sustained muscular contraction. And this muscle contraction can cause muscle weakness or muscle lysis, rhabdomyolysis, which in turn causes a hypermetabolic state. Because of the increase in metabolism, there is increase in anaerobic metabolism, which in turn can lead to acidosis. So what is the problem because of all this is what we will encounter in our clinical scenario. So in the clinical scenario, we have to know what triggers this response, whether all the patients will have this response or anything will trigger. So for that, we have to know what are the triggers of malignant hyperthermia. If we see among general anesthesia agents, the volatile agents are the culprit here, especially the halothane, which is not used nowadays widely. We have the isoflurane, sevoflurane, desflurane, and in the muscle relaxants, depolarizing muscle relaxants like succinylcholine is the culprit. Whereas the other agents like propofol, ketamine, or opioids, or local anesthetics, or nitrous, they are considered as non-triggers, or basically they're considered safe in MH patients. So we also have to know when we are giving a trigger in any patients for anesthesia, is it necessary that all the exposure to anesthesia will trigger such response in my patient? It is not necessary again because it has been reported that only half of the patients have had an fulminant malignant hypothermia, whereas other half they had a very uneven full exposure to even the triggering agents. And why this discrepancy? That's mainly because how we administer our anesthesia. In whatever available literature, they say that when we pre-administer certain drugs like barbiturates, like propofol, or when we do give some amount of non-depolarizing muscle relaxants, it actually delays or it can even prevent the onset of MH in certain populations. And there are also reports stating that the patients who had MH or the patients who had previously they have tolerated general anesthesia, but now they have developed malignant hyperthermia. Yes, it can happen. So we also have to be aware of these scenarios. So how your patient will come to our OT or how a patient will behave in our OT, there are two scenarios. In one, my patient received thiopentone and scoline induced, and then immediately the patient will develop a masseter spasm. This should give you a suspicion that the patient is more prone to develop malignant hypothermia, and the symptoms will progress very rapidly. Whereas the second patient, they will have a normal response to intubation and induction and intubation. And even the course of anesthesia will be uneventful, but at one particular period of time, they will start developing all the symptoms. So that's when we have to raise a suspicion. So what are these symptoms we are worried about is the first earliest symptom to occur in a patient with malignant hypothermia is unexpected rise in the EtCO2 level. And this rise will be very rapidly progressing within even 5 to 10 minutes. And we also have some amount of unexplained tachycardia, which can be associated with a sinus tachycardia or ventricular tachycardias, which can progress to even arrhythmias. And if we see there is some amount of muscle rigidity, but this muscle rigidity, it is very difficult to appreciate in a patient who's already under general anesthesia. So we can see that the chest wall compliance and those things can be affected because of the rigid muscles, and it will be difficult to ventilate such patients in this scenario. And because of the hypermetabolic stage, there is also increase in the temperature. And this increase in the temperature is actually, it will have more than 1 degree Celsius of rise will be there for every 5 to 10 minutes. And the temperature can even go beyond 40 degrees centigrade. And because of all these hypermetabolic changes and muscle rigidity, there will be some skin changes and there will be also hemodynamic instability. So what is the metabolic changes we will encounter once we do an ABG, arterial blood gas analysis in this patient is, we will have a mixture of respiratory and metabolic acidosis, which is mainly the lactic acidosis we will encounter. And when we see the venous blood gas analysis and arterial blood gas analysis, usually there is a gap of around the 6 mm of Hg. Whereas here, the gap actually widens. The difference between the CO2 level in the venous and arterial level will be very wide. And if I compare the CO2 level between the EtCO2 and the arterial CO2 also, there will be reversal of the gradient will be there. And there will be also hyperkalemia in these patients, and the potassium level will be usually more than 5.5. So how we will go about this patient is, we will have a set of clinical scoring system. So this scoring system is called LARAC scoring system, and this involves parameters like muscle rigidity, whether there is any evidence of muscle breakdown, that is rhabdomyolysis, and whether there is respiratory acidosis and how severe the respiratory acidosis is, and how much temperature changes are there. Depending upon all these parameters, they have given a scoring system. So This scoring system is called CGS scoring system. This will tell us retrospectively, we can assess ourselves. Retrospectively, it will tell us whether my patient had, whether whatever symptoms my patient had, whether there is any likelihood of malignant hyperthermia. So it will give us a prediction that this is actually malignant hyperthermia. It helps in that way. So once we know that this is malignant hyperthermia, how we will go about managing these patients? First thing first, we know all about the triggering agents. So we have to discontinue all the triggering agents. How we can do that? We have to, as much as possible, we have to try and disconnect the patient from the anesthesia ventilator. So first we disconnect and then we can ventilate in a semi-open system. That is the Bain circuit. We can take a Bain circuit, change the circuit, and we can try to ventilate. What else we can do is we can also hyperventilate. We have already seen the patient will have increase in EtCO2 levels and everything. So we can try to hyperventilate the patient with 100% oxygen. We can increase the fresh gas flows to even 10 liters per minute. And as much as possible to maintain the anesthesia if required, we can even use intravenous agents like Tiva, propofol, opioids, and even we can switch to NDMRs if applicable. If there is dantrolene available in our institute or in your institute, we can even give dantrolene intravenously in 2.5 mg per kg dose, and we have to maintain with a continuous infusion. Sorry, excuse me. And one more important management what we have concerned about is the active cooling of the patient. This is very, very important because the temperature will be rising very rapidly from 1 degree Celsius for every 5 to 10 minutes. So we have to give cold IV fluids, we have to use ice packs, we have to use continuous gastric and bladder lavage, and at all costs, we have to make sure the temperature is less than 38 degrees Celsius at all points. So what is the other management we do is there is so much of metabolic abnormalities which is happening in these patients. So what we can do is we can continue bicarbonate infusions. And we also we were also speaking something about rhabdomyolysis, which can cause AKI in certain populations. So we have to maintain adequate urine output. We can even administer Lasix. And whenever there is hyperkalemia or arrhythmias, we have to manage accordingly. So for all these things, we have to continuously monitor the blood gas analysis of the patient, if possible, or if there is you have a good laboratory investigations available immediately, we can even send the patient's blood for assessment of CK levels, CKMB levels, and LDH levels. So what is this dantrolene we are talking about? Dantrolene is nothing but it is a postsynaptic muscle relaxant. It is a widely FDA approved treatment for the malignant hyperthermia. What it does is, it intracellularly, it blocks the ryanodine receptor and then it reduces the calcium efflux, calcium coming out from the sarcoplasmic reticulum, so that it subsequently causes muscle weakness. The dose of the dantrolene is around 2.5 mg per kg, and it is available in various formulations from 20 milligram per vial to 120 or 250 milligram per vials. What we have in India is right now we don't have any dantrolene manufactured or provided in India. We have to export it from abroad countries via certain pharmacy companies. And we can, for example, we can even get this 120 milligrams of dantrolene can be obtained if we have any contacts from the pharmacy companies, which will be exported from the US or European countries. So it is not available immediately, even if we need access. So unless otherwise we have stocked it prior, thinking that we might require in future, it is not available immediately for that particular patient. That might be the scenario. And now we have seen what will happen in the OR and how a patient will manifest in the OR. Now, what to do when I have a patient who's high risk for developing malignant hyperthermia? So how I will know my patient is high risk is when my patient is giving some history, like I already had some history of malignant hyperthermia and I have been informed about this. Or I have a relative and that relative is a known case of malignant hyperthermia. So in that case, how I will go about it? So the management here will involve mainly the type of anesthesia we choose. So here, since the patient is already a known case of or a high risk for malignant hyperthermia, I try to avoid GA as much as possible. So here, regional is considered to be a safe and preferred one. Even if I choose general anesthesia, we can opt for Tiva with propofol. So, but if in case we are opting for GA, we have to avoid the volatile anesthetics as much as possible, and we have to avoid the succinylcholine. If you are using an anesthesia workstation, it is ideally recommended to use a workstation dedicated for patients with malignant hyperthermia, but it is not possible in our Indian scenario. So what we can do is we can do something called anesthesia machine cleansing. So we can remove the vaporizers from the machine. We can flush the whole anesthesia workstation as per the manufacturer recommendations. And if I'm using fresh gas flows, I have to use a high fresh gas flows, because using low fresh gas flows, what it happens is it actually causes reaccumulation of the volatile agent, and it can trigger an MS response. In all the patients, we have to try to monitor the temperature and EtCO2. If possible, we can have some printed malignant hyperthermia checklist inside our operation theater, so that we will have a prompt response, and we can even see how accessible we are to the dantrolene. So we can have contacts within our city or within our state to know whether we have dantrolene access or not, so that it will help to manage such cases in the future. So what will happen? What we have to do once the patient has developed hemorrhage, I have given management. So what I have to do next? This is also important because the patient requires a critical care monitoring for minimum 24 to 48 hours. And we have to send blood investigations for CK levels, LDH levels, creatinine levels to assess whether the patient has developed any AKI, and constant monitoring of ABG is required. And if any if any complications has developed like DIC or renal injuries, we have to treat accordingly. If possible, and if you have sources, you can even send the blood sample for testing the patient whether the patient is a genetically susceptible individual. And the more important thing after the response is the documentation. That is, we have to document the events, and we have to give some malignant MH high risk case like that, a documentation to the patient. And we have to warn both the patient and the family about what has happened and about the future anesthesia plan. It has to be explained to both the patient and the patient's party. So what is this genetic testing we are talking about? The genetic testing, there are two types of testing actually available for patients with malignant hyperthermia. One is the gene testing, where we test for the presence of ryanodine receptor mutation or the DHPR mutation. And there is also something called contracture testing, which is considered as the gold standard for diagnosing a patient with malignant hyperthermia. There are two types, that is in vitro contraction testing and caffeine halotene contraction testing. All this testing, they have some varied sensitivity and specificity, and they are also not clinically precise to use, especially in our Indian population, because these testings are not actually done in all the centers or across the country. It is only done in certain centers in certain metro cities only, and not in all the centers. And they are also not 100% reliable, because the mutation itself is very variable, the variable penetrance, and there is also mutations which is involving other unknown genes. So we can't 100%, we can't rely on all this genetic testing. So seeing all the whatever scenarios which has happened and what is the actual physiology and pathophysiology, we'll see what is happening in our India right now. What we can see is, this is the reported literature in our Indian population. We have like almost around 10 cases which has been reported till date about whatever malignant hyperthermia has happened. And in the rightmost corner, the last column, if you see what is the onset of symptoms, it just gives you an idea. The symptoms will happen at varied time points. Certain patients, it has happened within 5 minutes or 10 minutes, and certain patients, it has happened even after the surgery in the post-anesthesia care units. So the onset of symptoms will vary like anything. So we have to be cautious about that. And in all these cases, only 3 patients have expired. All the patients have survived from supportive care. And in only one report, they have mentioned the usage of dantrolene. So to conclude about our Indian scenario, there is no dedicated malignant hyperthermia registry or anything we have. So it is actually underreported. So what we see now, or what we saw in the previous slide, might not be the actual prevalence, because we might not know what is the actual prevalence of malignant hyperthermia in our population. So suspicious, we have to be having a very high clinical suspicion. And we don't have any access to genetic testing or contracture testing like how we do for other testing. So there is very minimal access. So we have to completely rely on the diagnostic criteria rather than the definitive test. So that is one drawback what we face. And the other one is the dantrolene availability. We don't have access to dantrolene immediately if we know that our patient is having malignant hypothermia. So we have to constantly rely on our prompt supportive care. That is the one thing which helps and which even saves the patient, so that we have to make sure that we are trying our best to give a good supportive care, even though that there is lack of availability of dantrolene in our centers. So the take-home message here is, we have seen the malignant hypothermia and everything. It has a high mortality if we don't give a prompt supportive care, and the onset of syndrome is extremely variable. So it can even happen in the PACU that we have seen. And even if I don't administer any anesthetic triggers, will I have any clinical suspicion? No. It is actually documented that it will not happen if there is no trigger. So that we have to be sure about. And we have to monitor for the signs very vigilantly. And the first sign to happen here is the hypercarbia, that is accompanied by increase in the ATCO2 levels. And we should be highly suspicious of all these symptoms when we are using the triggering agents. And the supportive care is very, very crucial to prevent the mortality in these patients. Thank you.
Thank you, Dr. Banupriya. That was really fantastic, right from pathophysiology to management to prevention and to detection. We'll have the questions at the end. Now I'll call upon Dr. Sireesha. She will talk on anaphylaxis. Dr. Sireesha, please.
Yes, sir. I think the host has to allow for sharing my.
Banupriya, you can please stop sharing. Yeah, Sireesha, now you can click.
Yes.
You will be able to share.
Yes. Can you see my slides, sir?
Yeah, it's visible. Please go ahead.
Thank you, sir. Good evening, everyone. I would like to thank ICA team and Kundra sir for giving me this opportunity. Today, I am Dr. Sireesha, working as assistant professor in JIPMER. Before I begin, I want to declare I have no conflicts of interest. So first, I want to walk you through the case scenarios. Can you see my slides, sir?
Yeah, we can see the slides, Sireesha.
Thank
you.
So,
Any issues
the
with
first
your end?
case, if you, I can see now, sir. Thank you, sir.
Okay, bye.
We'll begin with the first case. It's a 42-year-old woman undergoing laparoscopic cholecystectomy under general anesthesia. Suddenly develops severe hypotension and bronchospasm within minutes of receiving propofol and rocuronium. And as per the history, there was no prior allergy history was documented. So in this scenario, what would you do next? And can it be an anaphylaxis? We have to think about it. And there is another case. It is under spinal for a 37-year-old male. After giving spinal anesthesia with 0.5% of hyperbutane, he was given IV vancomycin 100 ml normal saline. Soon after started, he complained of intense itching and breathing difficulty. And his blood pressure fell to 68 by 33 millimeter of mercury and heart rate 76 per minute and saturation 97% on lumen. Thinking it was post-spinal hypotension, we administered mefentermine in repeated boluses up to 15 mg. But BP was continued to drop to 55 to 30 mmHg and saturation to 94%. It is not responding to mefentermine. So what is your next plan of action? So I am just going through these, showing these two cases, one from GA and one from spinal, because their anaphylaxis in a real scenario, it is very close to the clinical practice, which happens suddenly in OR with many confounding factors. Even to the experienced anesthetist, it's challenging, which requires immediate and systemic management. So let's go into the definition. Upon many definitions, it was the definition from WHO, which are given like anaphylaxis is a severe life-threatening hypersensitivity reaction characterized by, it is a systemic hypersensitivity reaction characterized by being rapid in onset with potentially life-threatening airway, breathing, or circulatory problems, and is usually, although not always, associated with skin and mucosal changes. Here I'm especially particularly highlighting about not always, because in in perioperative setting, under the drapes and all, the characteristic sign, the characteristic sign of the anaphylaxis, like skin and mucosal changes, cannot be elicited as fast as possible. Sometimes we cannot be seen, that cannot be elicited as an early symptom also. So coming to the incidence, the numbers from various researchers, it was given like we are seeing 1 in 18,600 to 1 in 353 anesthetic procedures. If you see there is a large difference in the denominator, it is because mainly because of the underreporting. Usually the mild and moderate symptoms of anaphylaxis are mostly not reported, and also because of the diagnosis, many of our centers doesn't have any laboratory facilities to diagnose it as definitively. That is one reason there is a large difference in the numbers. And according to the recent national audit project of 6th national which held in UK, severe life-threatening anaphylaxis like grade 3 and grade 4 was estimated at 1 in 10,000 anesthetic procedures. And also in children, it is very less comparatively, 1 in 37,000 cases. If you see the mortality, it ranges from 1.4% to 4.8%. It is also differs in different locations. So what I'm saying is, because of the underreporting and also because of the challenges in diagnosing it, is definitely because of the less laboratory facilities. The numbers what I'm showing is like tip of the iceberg only. And mechanistically, if you see, anaphylaxis is broadly divided into immunologic and non-immunologic. And in immunologic, they're further divided into IgE mediated and IgG mediated. These are very allergen specific. And as we know, mast cells and basophils are the most common cells, immune mediated cells in our body, which helps in the inflammatory pathways. These are the target cells or effector cells in anaphylaxis, which undergoes degranulation and release of the many chemical mediators. If you see this picture, the most common allergic pathway. So in our body, whenever the B cells in our body from the plasma, they exposed to antigen or allergen or drug which are act as an allergen, they produces IgE antibodies. These IgE antibodies bind to the surface of the mast cells or basophils. So after subsequent exposure to the same antigen, they bridges the gap between the two antibody molecules by cross-linkage and causes degranulation of the cells and release of the histamine and other mediators. This histamine will increase the permeability and distension of the blood capillaries. And apart from the IgE mediated or immune specific pathways, there are other non-specific or non-immunologic pathways which we commonly see in the perioperatively. In these pathways, they directly act on the mast cells or basophils without any antibodies. So most commonly, neuromuscular blocking agents and fluoroquinolones, they activate the mast cells. They directly attack the mast cells by MRGP or X2 activation, and antibiotics like vancomycin through calcium and phospholipase dependent mechanism, and some NSAIDs by COX-1 inhibition, and there are some unknown pathways. So either it is IgE mediated or non-IgE mediated. The most common effector cells are mast cells and basophils. Apart from that, non-IgE mediated or non-immunologic pathways also act on other cells apart from the mast cells and basophils, like neutrophils, smooth muscles, mast cells, and eosinophils, and that causes release of the chemical mediators like histamine, tryptase, leukotrienes, thromboxane 2, and platelet activating factor, and many complement factors. These factors will injure the endothelium and causes capillary leakage, which leads to vasodilation and smooth muscle contraction, which leads to bronchoconstriction and results in wheezing or hypotension or flushing, edema, tissue edema, and all those things. So now coming to the common perioperative triggers, according to the recent national audit project, it was found like antibiotics are the most common perioperative triggers which is causing anaphylaxis, and followed by neuromuscular blocking agents. In that, most common is rocuronium, followed by atracurium and succinylcholine. And there are some case reports even on the sugammadex, and followed by chlorhexidine and dyes, which are using intraoperatively by the surgeons. And also the remaining part for the latex, propofol, and heparin, and barbiturates, whatever we are using, the protamine, ibuprofen, all etc. These all comes under. So around 80% is covered by the antibiotics and neuromuscular blocking agents, and it is not same in all countries. Even it differs in some countries. Some countries it is neuromuscular blocking agents that is causing more, that is the most common perioperative trigger, and in some countries it is antibiotics. In India, it is most commonly with opioids and neuromuscular blocking agents, followed by transfusion reactions. Now, coming to pathophysiology of anaphylaxis, as I have told, after degranulation, because of the release of the chemical mediators like histamine, tryptase, and all those things, this will cause damage the endothelial barrier and cause capillary leakage, which leads to decrease in the preload and severe vasodilation, which leads to hypotension and with compensatory tachycardia. And also, mostly when the patients under GA, because of the positive pressure ventilation and intrathoracic pressure, rise in intrathoracic pressure because of bronchospasm, it will further decrease the venous return, which leads to RV underfilling. Ultimately, it leads to decrease in the LV output, sometimes presented with pulseless electrical activity with refractory shock. And also, whenever there is an anaphylaxis, there is an endogenous catecholamine surge, which leads to which leads to release of histamines acting on the cardiac H2 receptors and beta blockers, beta receptors, which promotes the tachycardia. Predominantly, it is tachycardia we'll see, but occasionally we might see bradycardia also because of the profound venous decrease in the venous return. By that, there is a stretch receptors which leads to release of the chemoreceptors or increase in the aggravate the vagal response by the Bajol-Jarisch reflex. So from this pathophysiology, in the cardiovascular, what are the cardiovascular implications of anaphylaxis? Or sometimes among the mediators, histamine will cause coronary artery spasm, which leads to coronary artery ischemia, coronary artery spasm, which leads to ischemia and myocardial depression. Sometimes they might present with ST changes, low AF, which mimics the acute coronary syndrome. And also during this time, it is mainly, if you see, there is a distributive shock. There is a decrease in afterload and there is a decrease in preload. But the contractility is good in these patients, so which leads to hyperdynamic underfilled LV. In this scenario, if you had given epinephrine to the patient as a treatment, it will induce a left ventricular outflow tract obstruction. That will further worsen the hypotension and which might mimic the obstructive shock. And because of this vasodilation, because of the massive capillary leakage, there is a splanchnic sequestration. There is a large pooling of blood in the lower abdominal vessels, which is called a maldistribution. Maldistribution is nothing but the blood volume is not lost, but it is redistributed to the larger vessels, which results in the profound hypotension. And there is a unresponse, even though after many fluids, it is not responded to the fluids, which mimics the cardiogenic shock. So coming to the respiratory implications, because of the histamine and other mediators, it will disrupt the alveolar capillary membrane integrity, which leads to capillary leak syndrome. Ultimately, patient lands up with pulmonary edema. Even though this pulmonary edema is not, since it is not caused by cardiac failure, we will see normal pulmonary capillary wedge pressures in these patients. In view of, in attempting to improve the hypoxia, if we give the high PEEP, that will lead to increase in the alveolar pressures and will cause more leak across the fragile membranes. And also, in anaphylaxis, there will be even upper airways and the lower, both will be affected, causing bronchial and tracheal mucosal edema, which will decrease the lung complaints and increase in the airway pressures and all. So ultimately, because of the severe anaphylaxis and delayed fluid resuscitation, or because of this trying to attempt for the mechanical ventilation to further improve the hypoxemia, also will worsen it. And also asthma and COPD patients, they have further amplify the baseline airway hyperreactivity. So it is very difficult to intubate. It is very difficult to ventilate in these scenarios. And it is very difficult to achieve the adequate tidal volume in these patients with normal peak pressures or without increasing the higher airway peak pressures. And coming to skin and mucosal manifestations in perioperative anaphylaxis, it is superficially urticaria, but if it is often first sign, but maybe missed under the drapes, or sometimes it might not be presented as a first symptom also. And other symptoms like angioedema may affect the face, lips, tongue, and airway. In severe scenarios, we might see the face, lips, tongue, airway, but sometimes it is only on the larynx and lower airways, which we cannot able to see also. So airway involvement may go unnoticed because of the intubation or due to the drapes. So after knowing about the pathophysiology, we should know about the grading also. This is the grading given from Ring and Messer scale, taken from Ring and Messer scale. Why should we know about the grading? Is to know about the severity, to assess the severity, and to know how fast we have to react and how far we have to go for the treatment. So in this, if you see in grade 1, it is very minimal, like erythema, urticaria. So supportive treatment with the corticosteroids and antihistamines will be enough. In grade 2, it is multi-organ involvement with cutaneous signs, hypotension, tachycardia, bronchial hyperreactivity. And in grade 3, from grade 3, it started severe life-threatening multi-organ involvement, where we should take very serious and act very immediate in these patients. Patient might collapse and they will show severe tachycardia and or bradycardia with arrhythmias and some profound hypotension, which end up in refractory shock. And grade 4 is some people might show cardiac or respiratory arrest. So which patients might fall into the risk of anaphylaxis? Patients who have had an allergic reaction during previous anesthesia, or patients with the atopic dermatitis or history of allergies to drugs or other than anesthetics, food allergy, or patients with asthma or COPD or allergic rhinitis, and patients with mast cell disorders. And also patients with chronic beta blocker or AC inhibitor therapy may not be prone for anaphylaxis very frequent, but they will not react to the treatment what we are given to the given for the anaphylaxis. This is very difficult to treat these patients. Now coming to the differential diagnosis, as we know in perioperative settings, there are many confounding factors which will confuse us to diagnose early anaphylaxis. Like these are the factors which might confound intraoperatively, like hypovolemia and hemorrhage might happen, which should be distinguished by blood loss. You have to check for blood loss in those scenarios, and myocardial ischemia. We have to rule out with the ECG changes, troponin rises, and any allergen exposure history. And cases like pulmonary embolism also might collapse with the hypoxia and hypotension and severe tachycardia. So risk factors like DVT and high peak airway pressure is unlikely unless cardiac arrest. And there are tension pneumothorax. All these might present with sudden hypotension and desaturation. All this should be correlated with other, it should be distinguished with other factors before we are attempting the treatment. Now coming to the management of the perioperative anaphylaxis, it has taken from the standard guidelines. So the main 3 cornerstones of treatment is early recognition and resuscitation, and early adrenaline administration, and volume expansion by giving rapid IV fluid boluses. Let's look on to each topic. So early recognition. So if you see, it is very difficult to find the early recognition is the key factor for the outcome of the anaphylaxis. In the perioperative settings, compared to the other settings, it is difficult to identify the anaphylaxis, especially if you see in other settings, upper airway tract and laryngeal edema patient might be telling about as throat tightness, change in voice quality as such. But in perioperative settings, you will identify with the difficulty with intubation and all. In case of, if it is involving lower respiratory tract or bronchospasm, there will be shortness of breath and wheezing and repetitive cough in other settings. But in perioperatively, you will see increase in ventilator pressure, which needed to inflate the lungs, and increase in end tidal CO2, and decrease in the arterial oxygen saturation. And also coming to cardiovascular systemic system or hypotension. Hypotension is the first symptom which will be most commonly elicited in the perioperative settings. And also arrhythmias and cardiac arrest are also more common. And coming to skin, it is mostly underreported, or we can under the drapes. It is difficult to identify. Patient also cannot report anything because of sedation. So early recognition by seeing the perioperatively by seeing these ventilator parameters and other monitor settings are very important. So immediately after diagnosis, what we have to do is first we have to call for help, and we have to alert the surgeons. And based on the severity, we have to stop the surgery if needed and arrange for the cardiac arrest rolling. The assessment of the severity helps us in planning for extubation also. If it is grade 4 or grade 3 severity, better we not to extubate the patient, and we can keep the patient on mechanical ventilation for 24 or more than 24 to 48 hours. We'll assess and we'll stabilize the patient, and later we can plan for extubation. And third one is we have to stop or remove suspected triggers if possible. Whatever the drugs that time you're administering or administered before, or going to administer the same drug, it should be stopped and it should be kept aside. Then coming to the resuscitation part, the first and foremost thing is we have to give 100% oxygen. We have to, if it is under spinal, we have to secure the airway, preferably with the ET tube, and first attempt through VLS by an expert. If we have video laryngoscope availability in your setup, better to use the first attempt with video laryngoscope in view of airway edema and all. And ensure ETCO2 tracing and change to the inhalational anesthetic if appropriate. And coming to breathing, if there is severe or persistent bronchospasm, exclude the esophageal and endobronchial intubation and check the patent airway and anesthetic circuit. And nebulized salbutamol and ipratropium should be given via inline nebulization system. This is actually, we can give, patient is already intubated, so we cannot give externally nebulization. It is ideal to give, instead of disconnecting from the ventilator, we can connect the inline nebulization system or ultrasonic nebulizer through the inspiratory limb. For that, we need a separate oxygen source, either wall mount oxygen source or from the auxiliary oxygen source from the ventilator. So then we can consider IV bronchodilators too. And coming to circulation, consider immediately head down. As I told, there will be pooling of blood, splanchnic sequestration. There will be pooling of blood in the lower abdominal vessels and the large blood vessels. So consider head down and table tilt or elevate legs to increase the venous return and secure large bore IV cannulas and rush the crystalloids. If it is in adults like more than 12 years, 500 to 1000 ml, up to 3 to 5 liters you can give, and less than 12 years, 20 ml per kg. And avoid colloids and establish invasive monitoring as soon as possible if it is ready. Now, coming to the early adrenaline administration, according to the recent guidelines, it is recommended as a first-line treatment and the drug of choice. The mechanism of adrenaline is like through, it reverses the severe vasodilation by vasoconstriction and bronchodilation and inotropic and mast cell stabilizer. So whenever it says if in doubt, it's better to give start with adrenaline. So coming to the dosage of adrenaline and route of administration, it is, as in perioperative setting, it is preferable to give through IV, as it is already placed and easily available and faster absorption. And it is currently recommended is IV. First choice of route of administration is IV adrenaline. So initial IV bolus of adrenaline is around children of more than 12 years and adults, 50 micrograms IV with repeated boluses of every 2 to 3 minutes, and less than 12 years, you can choose 1 microgram per kg and titrate to the effect. If there is no IV to the patient, or if there is IV displaced, you can go with IM, but IM is, we know it's ease of administration by most healthcare staff too, but the disadvantages are like slower absorption and less predictable, and it depends on the adequate circulation. So the dosage of IM is around 10 micrograms per kg, maximum dose is around 500 micrograms IM. And immediately as soon as you have to secure IV or IVO access. Then when do you start the IV infusion of adrenaline? Whenever there is a poor response to the adrenal boluses, you can start IV infusion, and peripheral infusion recommended when there is no central venous access. Then use local protocol for ADR administration if it is available for faster action. If there is no local protocol, the recommended dosage for low dose IV adrenal infusion is 0.5 mg in 50 ml dilution, and you can start with 0.5 to 1 ml per kg per hour. Especially in case of moderate hypotension or moderate grade 2 or grade 3 scenarios, you can start with 0.2 mg per kg in moderate hypertension. Then you can proceed to 0.05 to 0.3 mg per hour in case of severe collapse. Then titrate according to the clinical response of the patient. Continuous monitoring observation is mandatory during the adrenal infusion and involve the ICU team very early. If there is refractory to adrenaline infusion, then what we have? You have to watch for systolic BP and then a hand-on pulse during all this time. And if systolic BP is less than 50 mmHg with severe bradycardia, and if there is no pulse or cardiac arrest happened, immediately start CPR according to the ACLS guidelines. And if systolic BP more than 50 mmHg with pulse not responding much to ADR infusion, then you can consider to add a second vasopressor like noradrenaline or vasopressin in addition to adrenaline. And in case of patients with beta blockers, you can consider glucagon 1 mg IV and consider steroids for refractory shock. And at the end, if not, you can consider if patient is not responding very much to these drugs, you can consider for extracorporeal life support. So what is the role of steroids in anaphylaxis then? Earlier, we used to, whenever we see the anaphylaxis case, we used to give hydrocortisone, we used to give antihistamines is our first reaction. But the primary action, but what now, after many researchers, it has proven that early administration of adrenaline has decreased the mortality. And the primary action of this steroids is the down regulation of the late inflammatory response, not early. So no evidence that corticosteroids can reduce reaction severity or prevent biphasic reactions, neither supporting their efficacy in the refractory anaphylaxis too. It will rather delay the appropriate treatment with adrenaline. So there is not recommended in the initial treatment of the anaphylaxis. It can be added as an adjunct to adrenaline to treat the refractory shock or bronchospasm. Coming to antihistamines, it is also not effective against the cardiovascular or respiratory features of anaphylaxis and do not improve survival. So H1 antagonist precipitates the hypotension, delays the appropriate administration of adrenaline and other treatments in the emergency setting. So it is also no longer recommended in the initial emergency treatment of anaphylaxis. It can be used to treat only angioedema, urticaria. Once patients have been stabilized, you should think about antihistamines only once patient has been stabilized hemodynamically. So after stabilizing the patient, you should look for the immediate follow-up or post-anaphylaxis workout. What are the available tests we have? It's like in vivo tests or skin prick test, intradermal test, and drug provocation test, and in many in vitro tests like serum tryptase, serum histamine, serum specific IgE levels, or also some of the basophil activation tests and complement activation tests. So immediate follow-up, what we have to do? Because of the mast cell degranulation, there is a release of tryptase into the circulation. So tryptase, it appears more than 30 minutes after symptoms and peak effect comes 1 to 2 hours after the onset, and its half-life is about 2 hours. So on it will normalizes in the serum within 6 to 8 hours. And coming to histamine, its half-life is around only 15 to 30 minutes. So during our resuscitation, we won't get, it is better to go with the tryptase sampling instead of histamine, because we won't see histamine after 30 minutes in the circulation. So as soon as anaphylaxis, after stabilizing the patient, we have to take 3 samples from the patient. One is immediately after patient is stable, and another one is 1 to 4 hours after the onset, ideally 1 to 2 hours to know about the base 4 hours. And after that, more than 24 hours after the event to look for the baseline tryptase values of the patient. These baseline values are important to take after 24 hours to interpret the dynamic tryptase rise in the patient. It is like significant if peak value is more than 1.2 into baseline plus 2 micrograms per liter, because every patient tryptase values will differ in each and every patient. So we have to compare always with the baseline values. That's why after 24 hours also we have to take one more sample and we have to interpret according to this formula. So, but if the absence of rise is not equal to the exclusion of the anaphylaxis, as I told, there are many factors which there are many chemical mediators, not only tryptase, like platelet activating factor, many factors are there which are causing the anaphylaxis. So all patients with suspected perioperative hypersensitivity must be referred to the specialist allergy service, and formal allergy testing is required, skin or in vitro tests. And there are referral forms from a national audit project it's like perioperative allergic network, which is giving a form with the anesthetic anaphylaxis referral form, which includes 5 pages regarding the perioperative events and the drug whatever is used. So when do you do a skin prick test or intradermal test? It is useful for the it is useful to do for the patient to whenever to avoid the next incident in the next coming up surgery whenever he posted. So it has to be done after 4 to 6 weeks of an acute reaction to avoid the false positive results. So always skin prick test should be done first, and it should be when it comes negative, then we have to it should be followed by intradermal test with recommended established non-irritating concentration. For skin prick test, we used undiluted neat 1/10 of per ml solution.
Sireesha, can you please wind up because we are exceeded the time
Yes,
to a
sir.
great extent.
Yes, sir. So these only 2 slides left, sir. So whenever there is a rise in wheal of around more than 3 mm, we'll be concluded it as the erythema or positive test. So this is how we'll be doing the skin prick test after 4 to 6 weeks of the exposure. So coming to lidocaine sensitivity testing, this is commonly doing in our routine protocol as before the surgery. Its true allergy is rare. It's less than 1% of local anesthetic reactions, especially most are vasovagal, toxic, or preservative related like methyl paraben. So what guidelines are saying is not for routine pre-op screening. It is indicated only if history of prior reaction or high suspicion is there. But when it is indicated is use of preservative. So when indicated, it should be used with preservative-free local anesthetic, and there should be stepwise protocol. First skin prick test followed by intradermal test in a graded subcutaneous channel. Must be done in monitored setting with resuscitation. So anaphylaxis is, even though it is rare, there should be high vigilance during the perioperative period because it is very sudden and very massive cardiovascular collapse will be seen. So adrenaline is the cornerstone of the treatment, and it is better to report every case. It improves awareness, builds national data, and guides prevention strategies. And it is better to identify triggers, document suspected agents. To identify the triggers, there is a proper documentation and arrange allergy testing and update patient records. And finally, the most important thing is team preparedness, that simulation training and readily available emergency kits and clear protocols will be enhance the survival. Thank you.
Thank you, Dr. Sireesha. I thank all the 3 speakers, Dr. Stalin, Dr. Banupriya, and Dr. Sireesha, for agreeing to be here with us and share their views on the 3 topics. Now we can, Madam, if you permit, we can have some questions for about 5 to 6 minutes.
Yes, absolutely, Pankaj.
Any questions, please? If you can just put it in your chat box, or you can raise your hand so that we can invite questions from all of you. Hello. Yeah, anyone who wishes to ask questions? Okay, may I just give specific points? First, Dr. Stalin, about the last. So my thing is that the issues can be that if you have given a caudal epidural in a child after general anesthesia, so how would you recognize that you have accidentally gone systemically? Is there any way of recognizing under general anesthesia when you give a block?
Yes, sir. First thing, while performing block itself, we should aspirate, sir. Like as I said, during the technique, we should take certain measures. When you aspirate, if there is even small amount of blood, we should abandon the procedure and we should redo the procedure, sir. That's one way of identifying. Second, use of ultrasound. Like nowadays, ultrasound is even used for caudal blocks. So use of ultrasound to some extent will help us to identifying that it has gone into the epidural space and not into the intravascular space. And third, the best way to identify is having some markers. Like if possible, you can use adrenaline, as I said, along with the local anesthetic, so that even under anesthesia, if there is a sudden rise in heart rate and blood pressure, that you can become suspicious about intravascular injection in the caudal space.
The issues are that normally they say that negative aspiration doesn't guarantee an intravascular injection because the amount of negative pressure which you create can collapse the vein.
Yes.
And then when you inject, you can go into the intravascular space. Secondly, caudal may not be able to differentiate because a lot of people use long bevel needles. Some of it can be inside the vessel, the other may go into the space where you can see the epidural space widening.
Okay.
So there can be issues, but I think the best way to do is to have a continuous ECG monitoring. And the first STP changes which you can recognize when you inject lignocaine with epinephrine are the hallmark that you are going into an intravascular into the vessel when you should stop injecting.
Okay.
So the other thing is, I just wanted to mention that yes, you should limit your topicalization dose for local anesthetics. It's good to write it down. But a better way would be that you give a vasoconstrictor like xylometazoline, which you give for preparation of the nasal passage before you anesthetize or give a local application, because that vasoconstrictor itself will limit the amount of absorption of the local anesthetic, which can happen from the nose and the mucosa. So I just had these two comments. Dr. Sood, you want to say something, madam?
Yes, first of all, lovely presentations by all three of them, really commendable. And they were very important topics, of course, these emergencies, and how the students should really know how to tackle them, immediately diagnose them. So everything was very well covered. I just wanted to say, yes, in our career, we have all seen local anesthetic toxicity, either in the caudal or while topicalization of the airway. Yes, we've done it. We've seen these things, and so also the anaphylaxis. Sometimes we still see that. Malignant hyperthermia, I think very few of us may have seen such an incident. And I do remember Pankaj way back in Chandigarh. So that was way back in 70s. There was probably one case, but after that, I've never seen. And as regards dantrolene, uh, as regards dantrolene, yes, I heard somewhere in Bala Venkat's WhatsApp that they have managed to get dantrolene. So maybe now the thing which was absolutely not, we used to sometimes get it from one private Nath Brothers in Delhi, but then of course it wasn't available. But I believe it's now available with our ISA. And most of the things as they have covered, so that was all beautifully covered. And the only message to the students, of course, is learn and be aware and vigilant and take immediate action. And as you said, Pankaj, about the ECG monitoring during caudal, it's so important because you just don't realize, and even if the patient is awake, you just don't realize that it's gone in the wrong place and the patient starts convulsing. So all these tips are very, very important. That's what I had to say. And definitely a lovely presentation by all three of them, Stalin, Sireesha, and Banupriya. And of course, your moderation is always the best.
Thank you. Ma'am, I just have to add one thing about malignant hyperpyrexia.
Yes,
So, Dr.
yes.
You have said that there are two triggers. One is suxamethonium, the other is volatile agents. So, if I may say that masseter spasm, when you give suxamethonium, is the first sign which you encounter when you have a person going into malignant hyperthermia. So just one drug has gone, and then if you are warned with a masseter spasm, you will not go ahead with an inhalational agent. That is the way you deal with it. So those patients have a better prognosis because you may not proceed with the surgery. You may immediately cancel the surgery saying that we are into a problem. It's going to be a medical emergency. And because only suxamethonium has gone. But when you give inhalational agents with other induction and muscle relaxants, you give the inhalational agent for a prolonged time. After 15, 20 minutes, 30 minutes, that's the time the EtCO2 starts rising, the temperature starts rising. So the recognition is late by the time the damage is done. And you cannot even halt the surgery. They may be halfway through, or they would have already opened up, and it will be very difficult to stop the surgery. So the prognosis in with inhalational agent is is not that good as with a succinylcholine, which can immediately warn you, and you may just stop everything and postpone the case and then manage the patient for MH. So that management starts very early. And but with inhalational agents, that management is delayed because of the other drugs which you have given, and there will be an issue. So it's always good to use to have early warning signs rather than anything else. The second thing is, you said avoid low flow gas flows. The problem is that low gas flows doesn't it doesn't have any effect. You can use low gas flows because what is being circulated is going to be used by the patient. It's not going to be vented out into the OT environment. So it doesn't matter whether you use high flows or low flows. The uptake of the inhalational agent would be the amount which the patient requires. Rest of it is going to be vented into the environment, so it will not make any difference. So I tend to have a difference of opinion that low gas flows can be used. But if you have a susceptible case of MH, now all workstations have a minimum mandatory oxygen flow of 200 ml. So it is meant to wash out the circuit and the remaining vapors in the canister, so that everything is washed off by the time the machine checks up. So that's one safeguard which already exists. But if there is a susceptible case, it's better to change the canister at least, because that's the place where you will not be able to wash out all the vapors. And also the circuit, have a new circuit for the patient to whom you are going to give, and you have a susceptibility, or you have probably think that this patient has is a high risk. So these two things, if you can do, it should be good to use that anesthesia workstation. So these are my points. The third thing I wanted to ask you, one of the problems with MH is hyperkalemia. And you mentioned that dantrolene also has a side effect of producing hyperkalemia. So are we looking at a patient where they can go into serious arrhythmias like VTAC and other things if dantrolene is also given in a bolus dose of 2.5 milligrams per kg? Just one or two responses from you, Banupriya.
Sir, it is actually to cause hyperkalemia, but there is no enough literature to prove or tell that how much severe that hyperkalemia is, because there's no comparison between the normal population and the patient.
Yeah, can you get the mic a little bit closer? We are not able to hear you well.
So now you're able to hear me? Yes, sir? Yes. So there is no enough literature to compare the usage of dantrolene causing hyperkalemia in normal patients and patients with MH. So they have said there is an increase in potassium levels, but there is no evidence to say how severe the hyperkalemia can happen. So it is just a warning they have issued to keep a monitor or keep an eye on the potassium levels with the serial ABG, so that the patient doesn't damage into any hyperkalemic consequences.
Thank you, Bhanupriya.
Yes, sir.
So, madam, from my side, the questions are over. If you have any, you're most welcome. And if any of the people who are listening to us, they can also put up.
Yeah, Pankaj, these people watch it on the YouTube later on, and then they ask the questions. So maybe they don't have any right now. And lovely presentations. Thank you so much, Pankaj, for moderating this. And your consultants are excellent, and they've told such valid points, which were, of course, very well presented. And I think it'll go a long way for the students to learn. So thank you all, and we hope to see you all again. Thanks a lot. Thank you so much. Thank you.
Thank you, madam.
Good night.
Thank you.
Good night.
Thank you, sir.
Thank you, sir.
Good night. Thank you.
Thank you.
Thank you. Bye-bye,
Oh.
Vineet. Bye-bye, Rashmi.
So
And
thanks to all the
Swastika, thank you so much.
So, thanks to all the dignitaries present here, Client is really glad to have all these brilliant people together in the session today, and I hope you all had a seamless experience. So, with everyone's permission, I'm concluding the session in here for today and looking forward to host you again. Thank you so much, everyone.
Thank you. Thank you.
Thank you. Good night. Bye bye.
Good night, all.